Thank you. Can you hear me? Okay. So yes, I'm a nurse practitioner / therapist, and my background, though, I started out for years. I'm a clinical specialist in child development, so I'm pretty grounded in normal child development, and then when kids have developmental disabilities, I worked for years at Riley Hospital. It's a tertiary care hospital in Indianapolis for the first 17, 18 years of my career. And I've worked in psychiatry for the past 20 plus years. So today what I'm going to talk about are a little information about medications that we use to help with challenging symptoms. As close to the mic as I can. Is that better? Okay. So we'll get started. I think what I frame it out in psychiatry because that's what I work in. But if you look at, and I think it should apply actually to no matter if it's psychiatry or neurology, or that when we start to work with families and children and adults with any disorder, but in particular we look at like the DCC, you have to first know, what are the diagnoses? Education about what does a diagnosis mean, what are treatment options. And oftentimes then another pillar that comes in is medication, using medications. And then it's not that just we prescribe medications and then we move on. There's environmental accommodations, additional supports, counseling, and a lot of education about the medications, how they work, what are side effects to look for, et cetera. But the one pillar that oftentimes is missed in management and is assessing for coexisting conditions. And I think if we look at with DCC, it's comorbidity, just like most psychiatric diagnoses, having comorbidity is having existing additional diagnoses besides just like the DCC or an ACC. It's what other conditions exist and that those need attention and may need treatment as well. And oftentimes that does, and again, I have a little bias. I get frustrated in medicine often that we've cut people into pieces and we deal with individual pieces versus looking at the whole. And I think to be effective, we need to look at the whole. And that's what assessing and addressing coexisting conditions should work toward that. Common diagnoses that we oftentimes see, and the other thing I should tell you is all these slides are on the Whova app under Documents, so you can refer to them later, and there's a way to export them if you want to do that. But the most common diagnoses that we see in child and adolescent psychiatry are ADHD, anxiety, adjustment disorders, and I'll go through some of these later and describe them in a little more detail and the medications that we use. Behavioral disorders, including oppositional defiant and conduct disorder, depressive disorders, learning disorders, bipolar disorder, tic disorders, and PTSD. And then if we look at adult psychiatry, the more common are the different anxiety disorders, including panic, OCD, phobias, depression, bipolar, eating disorder, substance abuse disorders or substance use disorders, ADD, psychotic disorders, PTSD, personality disorders, and dementia. If we look at the overlap, and again, I just did this slide here in particular for child and adolescent, but the same thing happens with adult disorders as well. There's a lot of overlap. If you have anxiety, if you have depression, often, those symptoms oftentimes look like anxiety, which can sometimes look like ADHD will look like that. Behavioral disorders look like that. So it's really honing down and trying to figure out what is the primary. And the presenting symptom is oftentimes just the tip of the iceberg. And I've had patients that, I can think of one in particular who had just real significant anxiety, and she was an incredible basketball player, but she kind of just shut down. She got overwhelmed. So we tried several different medications to treat the anxiety, and finally the mom's like, you know what, I've had this experience with my son, why don't we try to treat the attention issue? And bingo, we hit it. It wasn't her, she was anxious because she had a hard time staying focused, was so overwhelmed because there's so much information coming in when she was trying to play ball. So again, we have to kind of oftentimes do a lot of digging to figure out what's the primary symptom. Is there then something secondary, and from then know how to treat. And again, I always like this, is that it's easy to know something's not quite right, but it's harder to know that what is wrong, what's the problem. This is a chart that just shows, look at the overlap of symptoms between diagnoses. Like all of these diagnoses have behavioral symptoms. All except learning disabilities can affect appetite. All but learning disabilities as a rule affect sleep. There can be irritability and anger with all of them. Typically with ADHD and anxiety, there's not sadness, but there can be with all the other. And then interest and motivation is affected with all of these diagnoses as well. The importance of diagnosing the coexisting conditions is because we need to use medication to aim at the right target. And then we have to educate about the symptoms, about appropriate treatment, and that involves getting the right diagnoses, and then counseling to address the different, how to manage the condition, and then environmental accommodations. And that may be accommodations at home, at school, and again, I know some of the sessions that have taken place today have addressed that. When we look at criteria for diagnosing coexisting, the condition has to cause clinically significant impairment in social, occupational, or other important areas of functioning. Like if a person has a day where they're anxious and they're upset, but for the most part, they function fine, then we don't diagnose that as a disorder. It's like, okay, that person was anxious at that time, but it has to cause a degree of impairment in either at home, socially, or occupationally. Also, we have to know that it's not due to the physiological effects of a substance, like another medication. And in particular, I think of sometimes if you have adults, if they're abusing any substances, they can have some of these symptoms. Or I've seen patients who are on seizure medications. And the seizure medications can oftentimes cause patients to be tired, more irritable. So we have to rule out that that's not why the patient is presenting with those symptoms. And again, the DSM-5 is our Diagnostic and Statistical Manual for Psychiatric Conditions, and it defines very closely what criteria you have to meet to say that a person, so oftentimes I will use not otherwise specified, so maybe the symptoms are a little bit like sub-threshold, or they don't meet every, and in particular with children and adolescents, there can be issues that go on at school that can contribute. So oftentimes I will use not otherwise specified. This is kind of a simplistic image of the brain that I use for teaching purposes, but if it looks at kind of the overlap of where like mood disorders, including like anxiety, depression, et cetera, kind of the part of the brain they affect, where ADHD, and then where autism spectrum disorders. If you look in particular, there's the amygdala. It's a little red circle or oval toward the bottom, the hypothalamus, and the hippocampus. Those are all really critical structures in the brain that impact mood, impact anxiety, and I'll talk about how medications, oftentimes what we do is we work to get those structures working better. I always think of, too, if you divide the brain and you start lower brain functioning, if you just from the line where it says lower brain, that's people who have lower brain functioning are more vegetative. They're not they're not interactive. We're not exactly sure what happens in brains of people, but we know that as a rule they're not feeling, they're not thinking, they're not processing cognitively. The next part of the brain, the middle part of the brain, is where information comes into our brain through the middle brain, through all of our senses. And typically once information comes into the middle brain, the amygdala fires on. When that's kind of like a switch. And normally it fires on and then it goes off. And then it releases information up to the higher level. So that's more our cognitive, where we think about what we heard, what we saw, what we felt, and we process it. But when there is, again, a mood issue, or if that amygdala is not working right, it gets stuck on. And if you think of like a rheostat switch, you know, like you can dim or dull a light. If it's stuck on full, that amygdala, it traps information in the middle brain. And then the person can't think. They are reacting. They're not thinking through what they heard or felt or saw. If it's on a little, it alters their perception of what they just felt or saw or experienced. The other thing I think that's interesting too is if you look at more functional anatomy, where like reading, vision, hearing, taste, smell, speaking, those are the parts of the brain where those operations come from. And one thing I notice in particular is oftentimes, especially if you look at the sense of smell and hearing, how close those are to where like the amygdala in the middle part of the brain. So oftentimes sensory, I have patients who in the waiting room are undone if there's an obnoxious smell. There's a smell they don't like. I've had kids someone was eating McDonald's burger in there and they were like just totally on edge. I don't use incense or candles in my office for that very reason, because there are many patients, and I'm sure you probably see that with your family members or people that you work with who have disorders of the corpus callosum, that there are more sensory issues. I think smell in particular, the taste is connected in some ways to the smell, but the other also is hearing. Can also sometimes be very sensitive to smell, to the sense of hearing, and different noises can be very upsetting. And this is just a little more, this one is more scientific, a better image of the brain that shows, again, the different parts of the brain and how they're, the different senses that they're involved with. The other thing that we talk about then is not only structures in terms of the anatomy of the brain, but the neurons. And actually there's a typo on my slide. Neurons are the connectors. They're what help brain cells communicate with each other. And there are about 10 to the 11th power neurons in the central nervous system, and each neuron establishes about 10 to 100 connections with other neurons. It's not 10 to 10, it's 10 to 100 connections. So there's a lot of activity that goes on in the brain. And the neurons communicate by releasing or they either bind to or release different neurochemicals, which are called neurotransmitters. And I'll talk about, because that's when we use medications, we're aiming at the different communications between neurons and impacting the neurotransmitters. So again, neurotransmitters are the chemical messengers that they send messages between brain cells. In anything that's aminergic, and you may hear or see that in stuff you read, they function during a wakefulness. So you think of aminergic being awake, and those are like serotonin, dopamine, norepinephrine, and glutamate. Those are most common neurotransmitters. The cholinergic, they help more involuntary functions, and again, think of them as calm. They're more quieting, and they include acetylcholine and then GABA. It's gamma-aminobutyric acid. And GABA is, I'll talk about it here in a minute, it's one of the most widespread chemicals in the brain. A lot of medications, Neurontin, gabapentin, what they do is they increase the GABA, and so they have calming properties. So what GABA does, it calms down and keeps neurons from being so excited. They oftentimes, with other medications that they'll use, for people who have pain, will use medications that increase GABA, because again, it just quiets down, settles down nerve cells so that there's less pain. Another very common neurotransmitter is glutamic acid or glutamate, and actually it's a byproduct. When GABA breaks down, you get glutamate release, but it's very excitatory. So it can bind to 4 different receptors, and I'll explain receptors here in a minute. So it's involved in more than 90% of the excitatory functions of the human brain. And actually what they're finding is, like with bipolar disorder, where people have real extremes in mood, or when the brain, especially running on a mania, there's excess glutamate. So some of the newer medications are coming up with and developing are aimed more at glutamate is their target, to try to get glutamate decreased, because you don't want that hyperexcitability. If we look at the other neurotransmitters, there's norepinephrine, serotonin, and dopamine. And there's overlap in the middle. You'll see the overlap. They all affect mood, emotion, and cognitive function. Norepinephrine is one that's more responsible for people having energy, interest. So a lot of antidepressants will work by increasing norepinephrine. Because if people have low norepinephrine levels, they're oftentimes very tired, very unmotivated. Serotonin, again, more anxiety and irritability. A lot of the medications to help with anxiety and irritability are going to help increase serotonin in the brain. And I'll explain here shortly how sometimes, though, you won't want too much serotonin because then you get the opposite. It's called activation, where you get people that they're more hyper, just more excitable, and more impulsive. And then dopamine, it's a neurochemical that's involved more with drive, motivation, sex, interest, appetite, and aggression. What's interesting is with like serotonin, oftentimes we increase serotonin. There's one of the common side effects is there's decreased sexual function. And again, if you sometimes increase serotonin, you'll push down, it decreases dopamine or decreased norepinephrine. So these all work sometimes in unison, and other times they oppose each other. Okay, so now we have a neuron. Okay, so the first on the far, at the left, I get to be my right hand, your left-hand side, is a nerve cell, and there's the nerve body, and it's got an axon that comes off of it, and the axon is where chemicals come through that, and they get released. See the little fingers where the little projections are there to a postsynaptic neuron, and then I've separated off on the right-hand side of the screen. Chemicals come down, they get produced in the brain cell, like norepinephrine, dopamine, serotonin. They get released, and then they have to fit. There's a receptor site. They have to match. It's kind of like a key in a lock. There have to be specific receptors that recognize them and pull them in for them to be used. But how's, like some of the medications work, if you look at the little triangle with a dot, like SSRIs, they block the reuptake, because typically what doesn't get picked up by the postsynaptic neuron gets reabsorbed. So it blocks the reuptake. So it's kind of like, we think of it like putting a plug in a bathtub. You put that block there, and over time then you have more like serotonin molecules or more norepinephrine molecules. And then what the feedback loop then is the brain starts producing more because it recognizes it's not getting reabsorbed, so it needs more. So that's how it doesn't, those medicines don't work like boom right away. It takes a while. It can take weeks, sometimes months to see the full benefit, but we should be seeing some improvement in the process. But that's when you think of, because I think some people are like, what do you mean it blocks the reuptake? Because anything that you think of blocking, you think, oh, that's going to mean it's not there. But no, it blocks the reabsorption, so there's more available to the brain to use. The other thing that happens, so again, if you look at this where the synapse is where, again, that the vesicles hold it, they release it, and it gets picked up. We know a lot about, now there's what we call second messenger systems inside the postsynaptic neuron, where there are other processes that go on, and that's how a lot of the atypical antipsychotics, those medications work in that way. And so I always think of it like we put when we give some of those medicines, it's almost like putting a traffic cop in the brain. So say there's more serotonin, but you don't want too much serotonin in these, and actually some of the newer ones can almost read if there's too much serotonin, too much dopamine, automatically it's like building a thermostat, and it starts to block those things from happening. So that happens inside through second messenger systems. So it's a pretty complex process that's involved. So again, this just kind of looks at how the different molecules get black. And again, if it gets blocked, you have more molecules and more of the neurochemicals that are available for use. So a receptor is a chemical structure, and it's on the surface of sending and receiving nerve cells. So it either binds to or catches the chemical messengers. So if you don't have, and again, I'll show you here shortly, we do some testing that looks at genetics of patients. So we just do swabs, and it tells us, it lets us know based on their genes, are they like we call normal metabolizers, intermediate, or poor metabolizers. And a lot of it has to do with if they don't have the right receptors to pick up, they'll either not be able to use the medicines that we prescribe, and that really does help us a lot in terms of there's much less guesswork, if you will. So the medication effects occur when the receptor either blocks or inhibits reabsorption or catches it and brings it in. So that's how medicines start to work and can help with the symptoms of anxiety, depression, etc. Then the other thing, too, if you look at how medications, the estimated timeline, there can be ion channels. Those sit on brain cells, and a lot of medications that treat seizures are going to work more on that, and that's just on the membrane to kind of quiet things down. But then, like if you do second messenger formation, activated enzyme, if you look at how much time it takes, if you look at like 10 days, that's an average. But there are some medications that have they have long half-lives, but they can take several weeks for us to see the benefit. What we've learned is with medications, especially that have longer half-lives, is to start low, stay low, give it a chance to work before, because otherwise if you raise it too fast, we kind of overshoot our target. This looks at, again, I don't need to go into a lot of detail, but if you look at brain regions and neurotransmitters that are associated with different disorders, in particular anxiety, the norepinephrine, GABA, and dopamine, and again, it affects like all regions of the brain. ADHD, again, norepinephrine and dopamine, more in the frontal lobe and the striatum. Depression, serotonin and norepinephrine in the frontal lobe and the limbic area. And the limbic area is what I talked about before in terms of where the amygdala and the thalamus and the hypothalamus lie. And which is very interesting is those lie just below the corpus callosum. And I think too of the corpus callosum, I know it's a lot more complex than this, but it's oftentimes it connects the two hemispheres and facilitates communication. But I also think of it as almost like a insulation in part to help from the emotional brain from the thinking brain. And so there's less insulation, if you will. So again, when you have the limbic area, if the chemicals aren't right in it, you have a lot more depression. OCD is certainly a serotonin, and that impacts the striatum and the cingulate. Psychosis is dopamine and serotonin based, more the frontal lobe and the striatum. So you can see there's a lot of overlap in terms of where some of these disorders. Seizure disorders, the neurotransmitter on a lot of those seizure medicines is GABA, and it's usually in the parietal or temporal lobes, but it can be generalized to the whole brain. And the Tourette's and tic disorders, those are dopamine and serotonin based, and more in the basal ganglia and the frontal lobe of the brain. The other thing I'll talk about a little bit is what activates, what gets these neurotransmitters into brain cells, helps the brain receive them, and what things block them. And dopamine, there are like D1 and D2 receptors. Estrogen, so when they're like declining estrogen levels, there's less dopamine action, and that's where I think you think of like women who are postmenopausal oftentimes have more difficulty with word finding and memory because of lower dopamine. Nicotine is activating, and it's interesting, dopamine and nicotine receptors are very similar to one another. So people who have untreated ADD have like a 9-fold increase in nicotine use if they're untreated. Stress activates dopamine, and that's where oftentimes people who have ADD put stuff off to the last minute because they get stressed. And when they're stressed, they get down to after burning the midnight oil, then that's when they're prompted to get in and they can crank out a lot of work, but it'll be last minute. The other thing is exercise. Exercise helps stimulate dopamine, and it's blocked by the antipsychotic drugs. Serotonin, there are HT receptors, and they're before the synapse and after the synapse. And some of the medications work by blocking, and some actually kind of go around and have a way that they kind of glom on and pull the serotonin in other ways. Nicotine also stimulates the serotonin. ECT, which we don't use very often, but it is sometimes used for just very refractory depression. And then exercise. And I point this out, and you'll see on all of these, exercise helps. That's one of the things I look at. If I have patients who are not very active, and especially I think that happens if people have significant motor disabilities, you have to find some ways to keep them active, get them doing some type of, and it needs to be something that's enjoyable, but because the exercise, because I think if you look at how many people will sit in front of a TV screen or in front of a computer screen, and that just really puts them in a lot higher risk for anxiety and depression. And then things that block it are the tricyclic antidepressants and some of the antipsychotic drugs. Norepinephrine, there's a corticotropin releasing factor. It's a neuropeptide. Opiates, morphine, stimulant medications, and exercise. And it's blocked by acetylcholine. So we're going to look at some of the different medications that we use to treat anxiety, and you'll find that there's going to be a lot of overlap between those that we use to treat anxiety and those that we use to treat depression. When you think about generalized anxiety disorder, that's excessive worry about minor issues like perfectionism, worry about what others think, just worry about pretty much everything. I think people used to refer people as being neurotic, like they worry, and there are people that do worry about everything. And I think one of the things, too, that you look at with DCC, that because oftentimes they have a hard time connecting pieces, if they're not given warning ahead of time, there's increased anxiety. I mean, that's something, too. So I think they're at higher risk for having anxiety. But the medications that we typically use are the SSRIs, the selective serotonin reuptake inhibitors, of which there are Zoloft, which is sertraline. I put the brand name and then the generic name. But sertraline, I don't know that I have anyone on brand name Zoloft. Prozac, which is fluoxetine. Paxil, which is paroxetine. Luvox, which is fluvoxamine. Celexa, which is citalopram. Lexapro, which is escitalopram, Vibrid, which is vilazodone, and Trintellix, which is vortioxetine. And Vibrid goes generic in September. Trintellix, I'm not sure when its patent is up, but the others are all available in generic forms. But I will say not all generics are the same as brand name. And oftentimes their pharmacists will argue with that and want to push. Most of the time with SSRIs, people do fine on the generics. I do have a couple patients who have been very sensitive to medicine, and because the medications can be up to like 40% different, a generic from a brand name, because of different fillers. So if you have, and that's sometimes I'll have a patient, they're doing great, and then they start losing ground. A lot of the symptoms start coming back, and oftentimes I'll ask the parents, is it when you did the last fill, was it from the same manufacturer? So if I have patients that are real sensitive, I'm like, let's go back to the pharmacist and say, and I'll put that sometimes because we prescribe most medicines now electronically. If I know that they need something produced by Teva or another one, I'll put that down, like, okay, needs generic manufactured by, and I'll put the name of the company, because some patients really are that sensitive. Zoloft has an indication for children, adolescents, and adults. Prozac the same. Paxil. The Celexa, Lexapro, Vibrid, and Trintellix have indications more for adults. But oftentimes with kids, we will use things off-label if they don't respond to the ones that are indicated for children or adolescents. Buspar it's in a class of its own. It's a softer touch, if you will, on increasing serotonin. I always love when Dr. Ed Namus is the psychiatrist I work with, and she'll say, yeah, it doesn't have any side effects. Of course, it doesn't work. But I will say it works. I have a few patients it works on, but it's not, it's a pretty weak in medication to increase serotonin. But for patients that are real sensitive to slight increases in serotonin, it can work. It's got a short half-life, so it has to be dosed 2 to 3 times a day, which is kind of a drawback. Most of the SSRIs we use can only have to be given once a day. The other things we use for anxiety are the antihistamines, which you think of like diphenhydramine, Benadryl. Now, the downside is oftentimes those can make people tired, so you don't want people to be tired, but they can work for like acute anxiety. Vistaril or Atarax, which is hydroxyzine. I have some patients who've had, they get, like when they're anxious, they get hives. This works great for them, and they get like real itchy. Even if they don't have hives, they just feel real itchy, and this medicine works well for them. They typically take it at night, and the symptoms go away. And then there's chlorotrimazole, but I've not used that very often, but it works in the same way. It increases histamine. Another medication that is used is Strattera, and Strattera was initially developed, it's atomoxetine. We were thrilled when that was developed in the early 2000s because it was one of the first non-stimulants specifically indicated to treat ADHD, and it works as like an SSRI, but it increases norepinephrine and serotonin to the same. It's kind of like an SSRI, but it works more on the norepinephrine piece. But we were disappointed because the dosing for it to treat ADD, we switched some of the kids off of stimulants, and the nurses in the schools were going crazy because it can cause an awful lot. It's an acidic medicine. It has to be taken, swallowed whole. There's no liquid form. It can't be crushed or mixed in with anything because it's so acidic. But a lot of kids have had a lot of stomach upsets. But it does work if you have a child and they've not responded to other SSRIs. We just give it in the evening and make sure they have food before they take it. I tend to use it more second line. If I have a person who has ADHD with anxiety, it can work in that way. For generalized and additional medications for generalized anxiety are some of the antidepressants. We always start, there's different levels, but first line is always with the SSRIs or the more typical anti-anxiety meds. But there's tricyclic antidepressant Remeron. It's mirtazapine is the generic name for it. It works if people have a lot of anxiety and they have a hard time sleeping at night. It has its usefulness. The downside is, the other thing, if you have patients who because of their anxiety or because of their diagnoses, they're underweight, they oftentimes will gain weight with the mirtazapine, so it can be helpful. For others, you don't want that side effect. Then the others are SNRIs, and that stands for selective norepinephrine reuptake inhibitors. There's venlafaxine, Effexor, that's the one that's been around the longest, Cymbalta, duloxetine, and Pristiq. Effexor was the first one that was around, and it's one that the lowest dose it comes in is a 75 milligrams, and typically to affect both norepinephrine and serotonin equally, you have to get up to about 225 milligrams. And the higher you go on any medicine, the more risk you have of side effects. Cymbalta, it's similar. It's more sedating. It has more utility for people who have depression with pain because it helps on the norepinephrine end with the pain. Pristiq or desvenlafaxine, which is now also available generic, is preferred often because you can start, it's typically you start 50 milligrams and you stay 50 milligrams. You don't have to go up, you don't have to go down, although there is a 25 and there is 100 if we need to adjust. And it's balanced, meaning when you give it, it increases serotonin and norepinephrine equally. You don't have to go up on the dose to increase both of those. And then GABA-enhancing medications, they don't really increase GABA, but they mimic GABA, and they're calming, are the benzodiazepines. So it's probably a lot of you may have heard about or heard of. Valium, diazepam is one of the older ones. Transine or clorazepate, Ativan, lorazepam, Klonopin, clonazepam, and Xanax, the alprazolam. They get some bad press because they have high abuse and high addictive potential, but I will say we have many patients. I have many patients who are on them. They're great if you have a person who's got panic or anxiety, like before labs, before they have to have any blood work done, or just someone who's got generalized anxiety and the SSRIs are too activating or they can't go on a high enough dose of those to control the anxiety. These medicines work really well. Valium has a little longer half-life, as does the clonazepam and Ativan. The other ones are a little bit shorter, so oftentimes have to be dosed more than once a day. Another medication that's used oftentimes for anxiety is Seroquel or quetiapine, and it's used for treatment-resistant generalized anxiety in adults. It's got some good sedating. It's another one that's oftentimes used, maybe overused, to help people if they have trouble sleeping, falling asleep and staying asleep because of it's very sedating. And it increases, it's an atypical antipsychotic, but it hits histamine pretty hard, and I think that's probably one of the reasons it can be so sedating and help a lot with sleep. And again, medications that we use to treat panic disorder, and panic are episodes of intense fear accompanied by physical symptoms like heart racing, dizziness, shortness of breath. Oftentimes people, when they have a panic disorder, they'll end up in the ER because they feel like they're having a heart attack. The high-potency benzos, Ativan, Klonopin, and Xanax are first line for that. Again, what we try to do is prevent, because oftentimes this occurs in conjunction with the generalized anxiety disorder. So we'll use like an SSRI with a benzo, so it's combined pharmacotherapy. What you have to be concerned though whenever you have more than one medicine is you have to look at side effects and the additive effects, or if you give one, does it compete with the effects of the other? But I have several patients, again, I recommend, like this time of year, a lot of patients are terrified of fireworks. So I have a couple patients that they use more of like a benzo this time of year just to kind of help them get through this time when there's so many fireworks going off. Then obsessive compulsive disorder, which again I understand that can oftentimes we can see that in conjunction with the disorders of the corpus callosum, but that's OCD is excessive thoughts, which again are your obsessions that lead to repetitive behaviors, which are the compulsions. As a rule, the SSRIs are the first line. You tend to need higher doses to be effective. It's a pretty stubborn disorder. It can be very cause significant interference because people can't do anything because things have to be done in a certain way, and they can get very upset if things don't occur just as in their brain they feel like it should be done. So first line is fluvoxamine or Luvox, and again that tends to be pretty effective. Paroxetine, Paxil, I'll be honest, I don't use that one very often. I have kids or adults that come to me on that. It's got a short half-life, meaning if they miss a dose of it, they're going to feel lousy, and coming off of it can be pretty tough. So oftentimes what I'll do is if I have a patient, they've been on Paxil, and it's either not effective or compliance and taking meds consistently is hard, I'll switch them to a fluoxetine. Oftentimes, even if I'm trying to get them off of it, we switch to fluoxetine, which is Prozac, because it's got a very long half-life, and it helps prevent them from going through some of the like fluish type symptoms they can feel when they're trying to come off that medicine. Again, there is a longer acting form of it too. Again, I don't use it very often because I've had several adult patients say if I ever knew it was going to be this hard to come off if I never would have taken it. So when I have other options where I don't have that, people have that experience, that's what I tend to go with. Another is the tricyclic antidepressants, in particular anafranil or clomipramine, but that has to be taken at night because it is sedating, but it can be very effective for people who have refractory OCD. And then the other we sometimes use, I have a couple patients who are a combination of an SSRI with anafranil. Because, and the reason we would do that is they don't tolerate a higher dose of an SSRI. They have side effects from it, or going up on the dose doesn't help. So then I'll kind of go like an intermediate level on the SSRI and start with a very low dose of anafranil and build up as needed until the symptoms resolve. The other thing too is sometimes we have to augment, and the atypical antipsychotics are coming more and more having indications as an add-on to augment the effects. And again, what I look at them doing, because they work more on the second messenger systems, they kind of regulate. It's like building in regulators in the brain, especially some of the newer ones that don't have as many side effects as the older antipsychotic medications. If at any point you guys have questions, stop me, okay? And then in terms of post-traumatic stress disorder is when a person experiences unwanted memories or feelings from a past traumatic event. And I will be honest, I've had patients who've had PTSD from having hospital procedures where they were, held down and restrained and or even sometimes being separated because of a hospitalization, that they have some PTSD symptoms. So what we do with PTSD is we aim at the target symptoms, like is primarily if they're anxious generally, or more that they have significant sleep problems, or do they have psychotic symptoms where they're hearing things, seeing things. Because you can have those symptoms and it doesn't mean you're psychotic. It doesn't mean you're schizophrenic. Those symptoms can happen when you have just real significant anxiety or significant depression. And typically to treat PTSD, we use the antidepressants, including the SSRIs, the SNRIs, and the tricyclics. Blood pressure medications like propranolol, clonidine, guanfacine, and prazosin for PTSD sleep issues can be very effective. And I'll explain here in a little bit about those and how they work. But again, just like with other, when I've talked about other disorders, we sometimes need to augment with an antipsychotic medication, especially if they have any psychotic symptoms or depersonalization. And then in terms of what mood disorders, and there are several different mood disorders that can co-occur with disorders of the corpus callosum. Major depression or dysthymia. And I always think of chronic negativity and irritability as like dysthymia. People that never are happy, kind of like, woe is me. And it can be very tough to treat. But depression doesn't have to be sadness. It oftentimes comes out as people irritable, not being able to enjoy things, their appetites either increased or decreased, low motivation, and the symptoms to qualify as a major depressive disorder episode, the symptoms have to be present for most of the day, for a substantial period of the day, over a 2-week period. And there are brain and hormonal changes, and I think a lot of social stressors that occur from ages 9 through 10, up through the early 20s, that really place that population at increased risk for depression. I mean, that's what we look at our teenagers in particular. Actually, one interesting fact that I learned years ago is one of the indicators for depression in adolescents is declining math scores on testing. Because if you can have like language and verbal and kind of be in the ballpark, but math is very exacting. And if you've got mental fog, it interferes with the ability to perform math equations. This is a questionnaire that I oftentimes use as baseline. This is the one that's for adults, but they have one that's also indicated for teens. It's called the PHQ-9. It's a patient health questionnaire, and you go through 9 questions, and it's, I will usually use it during interviews. Sometimes people use it, having people fill it out when they're in the waiting room. I usually ask parents, if I'm with teens or I'm seeing school-age kids, I'll ask the parents and the kids, and I'll use different, like a square or a circle to compare. But it looks at, like, how often, you ask them, how often in the past 2 weeks have you experienced these symptoms? And the first one is you have little interest or little pleasure in doing things. And if they say it's like a nearly every day, and sometimes people will say, because the responses are 0, 1, 2, and 3, and they'll say like 4 or 5, but it's just, then you do a 3, and then you add it up, and when you get to the bottom, you look at what the total scores are, and then the very last question doesn't go into the numbers, but it's, if you have any of these symptoms, how much difficulties does it cause for you, like in getting along with people, getting your work done. What I like about using something like this is it gives me a baseline number, a measure, like how significant is this person's depression. And then once I start treating, I will repeat it 2 or 3 weeks later when I see them back and go through it again to see, has there been improvement? Are things no better or are things worse? But it's kind of a good way to monitor and even explain to parents and to patients the significance of their depression, because so many times they've been feeling this way for so long, they don't even realize, like, oh, that's depression, and yeah, that's depression. Okay, medications to treat depression are similar, again, like to the medications that we use to treat anxiety, the Prozac, Zoloft, Paxil, Luvox, Celexa, Lexapro, and Vibrid, and Trintellix. What's interesting, I think the Trintellix, they call it the 6-pack of antidepressants. It's got 6 different mechanisms of action. So for many, especially people who have, women in particular, who have slowed cognitive processing, it can be very effective. The Vibrid, I think of it as an SSRI plus. It works by blocking the reuptake, but it also has like a magnet part that comes around and like pulls in serotonin through a different mechanism. So it increases serotonin a little more effectively than some of the other SSRIs. The downside is some people are very sensitive to increases in serotonin, and if you increase it too much, they feel jittery, they feel nauseated, they don't feel good at all. Although the flip side of that, there are the 5-HT receptors that help serotonin get into brain cells. There are many 5-HT receptors in the gut. So oftentimes if people have a lot of significant nausea, we will use the SSRIs and that can help with that. So again, it can either make the nausea worse or it can make it better, just depending on the individual. Another, what we consider these atypical antidepressants are Wellbutrin, which is bupropion, and that we will use for ADD as well. But it increases norepinephrine and dopamine. Actually, it's renamed to help with smoking cessation. It's called Zyban. Again, I've talked about Effexor, Cymbalta, Pristiq, and mirtazapine before. So again, what they do is they increase norepinephrine and or serotonin, but through different mechanisms of action than the SSRIs. The tricyclic antidepressants that we use for major depression, and again, those are second line. We don't use those first line, are tofranil, which is imipramine. Sometimes they will use that for patients who have bedwetting. That can sometimes help with bedwetting as well for children. There's Pamelar, nortriptyline, norpramine, dizipramine, Elavil, amitriptyline, and enafranil. We use these if we need to. We have to be careful because they can be fatal if overdosed. As a rule, the SSRIs, you can overdose and it's not going to kill you. That's not the same with the tricyclic. So we have to be careful. If we have a person who's suicidal, I wouldn't be as inclined to use a tricyclic for that reason. So oftentimes we'll use a combination of, like if they're depressed and they can't sleep, I may use an antidepressant, and then I may use something to help with anxiety so they can sleep better. Because being depressed makes it hard to sleep, and not being able to sleep makes you depressed. So it's just can be pretty tough to know, like, okay, well, how best can we help this person get feeling better? And additional medications, there's a novel antidepressant, I don't know if any of you have heard of it, it's called Spravato. It's ketamine actually is a drug that's used in anesthesia, and I've had a couple of patients who've had ketamine infusions for refractory depression, but more they've used it for chronic migraines. But now there's a medication called S-ketamine, and it's inhaled. There are certainly centers you go to because you have to monitor vital signs like blood pressure and all that to make sure they don't their blood pressure doesn't drop off too much. They get monitored for like 15, 20 minutes. They go in initially twice a week for the first couple of weeks, and then after that it's weekly it can be several months at a time. It depends on the person's response. But it's been a pretty effective, pretty rapid response to treating depression. The other is we will augment antidepressants, in particular with Abilify or aripiprazole. You've probably seen the commercials on TV. I think that was one of the first atypicals that and then there's Rexulti, which is brexiprazole. It's a newer one, but again, they have an indication. Insurance will pay for them as augmentation. Rexulti does not have a generic, and I will say those medications, the atypicals as a rule, can be fairly expensive if they're not generic. Another novel medication that we use to treat depression is lamotrigine or Lamictal. It's an anti-seizure medicine, but it has some really good anti-anxiety and antidepressant effects. But we've learned with it, you have to dose low, depending on if it's a child. We start like at 12.5 milligrams a day for 2 weeks, and then you go up to 25 milligrams for 2 weeks, and then you can go up to 50. If it's an adolescent or an adult, we start with 25 milligrams a day for 2 weeks, then go up to 50 for 2 weeks, and then go up to 100. If you dose too high and too fast, they run the risk of developing Stevens-Johnson syndrome, which can be fatal, but typically it hasn't been, but they can lose, it's like an autoimmune. Their body starts turning on itself, and they'll lose their skin, they'll lose their toenails, or it can be pretty serious. So we always tell patients when we start them on Lamictal is any type of a rash, even if you think it's poison ivy, we'll have you stop giving it. It's always just better to be safe than sorry. I found some pediatricians to be really not like it because of that risk, But there's actually a greater risk of getting Stevens-Johnson from an antibiotic than there is from getting it from this medicine, and especially when we dose low and go slow. Once you hit the 6-week period, you're not likely to develop Stevens-Johnson from it. And again, for non-responders to traditional antidepressants, or we use a combination, like an antidepressant, sometimes with lithium, sometimes with a thyroid hormone, sometimes with stimulants, or there's a medication called Provigil or modafinil that's used for people who have narcolepsy. And again, when doing that, we're just trying to stimulate the brain, get the brain to wake up a little bit, and help people feel a little bit better. Bipolar disorder is manic depression illness. It's a serious but treatable illness. It's marked by extreme changes in mood and energy levels. And there can be, people cycle, we call them. They have depressive cycles, or they have manic cycles or hypomanic cycles, where their judgment's impaired. They're either too happy or too sad, or too irritable, can start very agitated. Any type of a brain insult can increases the risk of a person having a bipolar disorder, where their brain doesn't regulate their emotions well. And then some of the antidepressants can aggravate it as well. We have a mnemonic that we use to kind of go through, and actually I have this on a sheet that I go through, like it's SIG-E caps for depression. So there's increased or decreased need for sleep, interest or decreased, feelings of guilt, energy's decreased, concentration's decreased, appetite can be either increased or decreased, psychomotor movements can be either increased or slowed down, and then there's suicidal. To qualify as having like a major depressive episode, they have to have an irritable mood plus 4 of those for at least a 2-week period, or anhedonia, which is like not caring about anything, no interest in anything, plus 4 of those symptoms that last for about 2 weeks. And that would constitute a depressive episode. For mania, it's dig fast. That's kind of the mnemonic that we use to, like, okay. And so in my mind, I'll go through, if I don't have the sheet, it's like increased distractibility, insomnia. These patients can sometimes be awake for days, but they're not tired at all. They have a lot of energy. Grandiosity. And sometimes grandiosity, they come out as they know better than anybody else. I look at oftentimes defiance as a symptom of grandiosity. It's like, you can't tell me what to do. Oftentimes they know more than the parents, they know more than the teachers. And it's not like a teenagers, but I think a lot of teenagers think they know more than their parents, but it's different than that. It's the other is a flight of ideas. It's like a channel that keeps changing in their brain, and it's hard to keep up with them. And then increased goal-directed activities. Speech, talking very fast. Sometimes you have to, it's just hard to even know what they're saying because they can be talking so fast. And then thoughtlessness, doing things without any thought to it at all, but it's like they just act very impulsively and can be irrational. So for mania, they can have an irritable mood with 4 of the above symptoms, or a euphoric mood plus 3 of the above. So mania, especially in teens and children, is oftentimes not happy. People think of mania as being happy, but it can be just incredible irritability. And again, duration for mania, it only has to be at least 1 week. What's interesting is oftentimes I've seen children and teens diagnosed as being spoiled. I've seen it called a spoiled brat, being a behavior problem, that the parents don't have discipline, when it's not that at all. It's their mood is just. I had one. He was a kindergartner, and he was actually in he was in special ed and emotional handicap. It was a whole school that all the kids had because he had significant difficulties, but he was running across the elevators like, I've got 99 pizza, I'm going to sell 99 pizzas, blah, blah, blah. He was just going on and on and on. And the teacher or the principal of the school was like, that's not, he just needs to be disciplined better. I'm like, no. I mean, if you go through, like, he was talking so fast and those ideas. The other thing, too, that can be very interesting, and I've seen it a lot in my children, my kids, and my teens that I work with, is their drawings. When they can be like, when they're depressed, oftentimes they have very dark drawings, blood, knives, just very disturbing. The same kid, I just can think of him. I've followed him for a number of years. But then when he's manic, oh my gosh, there's butterflies and boats and sunshine and everything's happy. but can be very expansive as well. So oftentimes, again, they can tell us by some of their drawings how they're feeling. This shows too, like kind of what there's different mood disorders. Like bipolar 1 is where they have clear episodes of mania and clear episodes of depression. Bipolar 2 is they spend more of their time depressed, and they can have periods of being hypomanic, but they don't tend to go all the way up into mania, but can have periods of being elevated. And then mood disorder NOS is when they don't necessarily have extreme lows or extreme highs, but boy, their moods they're just not even at all. And they can be it's difficult for them to function. Because if your mood's off, it throws off your ability to focus at all. You can't pay attention, and it's just hard to function at home or at school, to be around people. And again, the primary symptom is a mood dysregulation. I was thinking, when you look at this line, a normal mood shouldn't have those big peaks and valleys. It should be more even, and certainly not have the ones that deviate that far from the normal, if you will, mood in the middle. The other thing too with mood disorders is that comorbidity is much more the rule. That it's rare that a mood disorder exists by itself. So oftentimes the most probably common that we see are anxiety, OCD, sleep disturbance, ADHD. Medications that we use to treat these are, the first line are the anticonvulsant mood stabilizers. Depakote, actually, and lithium, I'll talk about lithium here in a minute, are the two gold standard if we have a person who truly has bipolar. But the anticonvulsants work on cell membranes primarily. So again, they calm down the irritability of brain cell, just the membranes, versus working on particular neuroreceptors that I described before. The most common ones we use are Depakote, Lamictal, and those are probably the two most. Trileptal, which is oxcarbazepine, I tend to use that for kids who have more somewhat mild irritability or milder symptoms. What I like about it is if you'll know right away if it's the right thing, because they get better and they're less irritable, they're easier to manage. If it's the wrong thing, they'll be more irritable, and then you take them off. The other thing I like about Trileptal is we don't have to do blood levels. We don't have to check, like on Depakote, we have to do CBCs because it is metabolized by the liver, and sometimes it can make it interfere with platelet formation, so they have increased risk of bleeding. Doesn't happen often, but we still have to monitor for it. Depakote also, I've seen patients who have, and it's not in all patients, but something to do with its metabolism can increase ammonia levels. So I always check ammonia levels on patients who are on Depakote, because higher ammonia levels will cause fatigue, and any fatigue is going to cause more irritability and more depression and get in the way of cognition. I've already talked about Lamictal. Keppra it's an off-label use for mood stability. All of these are at the bottom, the Keppra, Gabatril, Topamax, and Neurontin. None of them have an indication by the FDA. We sometimes use them. Keppra, I don't use very often. I know it's used a lot for seizures, but I've just seen it cause a lot of irritability. And if they're on that, I believe it's vitamin B6 they need to take. That helps decrease their irritability. Gabatril has initially came out, but it hasn't not proven to be that effective. Topamax is used more as an adjunct. It can sometimes cause decreased appetite. So if you have patients on meds that are causing them to gain weight and have an increased appetite, the Topamax will help with that. And again, Neurontin is used oftentimes if they have more comorbid pain conditions, or it's used oftentimes for seizure disorders as well. And the other mood stabilizers I mentioned several times, there are neuroleptics or atypical antipsychotics, and they're called atypical because they are less likely than the original antipsychotics to have serious side effects. That's why they're referred to as atypical. The ones that, probably the oldest one on this list is the Risperdal or risperidone, and that can be very effective at low doses. It's got a short half-life, which means it oftentimes has to be dosed 2 to 3 times a day to be effective. I will sometimes have patients, we use this as a rescue drug. If you have your child just has periods of getting like real stuck thinking and really upset about things, or anxious, sometimes that helps, a dose of that, and it works pretty quickly. Zyprexa or olanzapine. The downside to that is it causes weight gain. I mean, I will occasionally have patients who don't gain weight on it, but for the most part, it's caused some pretty significant weight gain on patients. But we use that if I have patients who have significant psychosis and I need something to get in and work quickly, I'm going to use Zyprexa because as a rule, it works well. Abilify, it's got what we call agonistic and antagonistic. So again, it's more like the traffic cop type atypical. Seroquel, I mentioned a little bit before, we use higher doses. It has an indication for both high moods as well as low moods. Usually once you get past like 300 milligrams of that, we saturate histamine receptors and then the tiredness side effect goes away. Geodon or ziprasidone can be very effective. It needs to be taken with food to be absorbed. It has to be taken at night, or if you use it during the day, it will make people very sleepy. It's got some good antidepressant effects, though. Invega or paliperidone, it's like a time release. It's related to risperidone, but it's a time release. So sometimes we'll opt for that one if we know that, because anytime you have to dose a medicine more than once a day, but especially more than twice a day, compliance is tough. And I know you guys have, 4 times a day with meds? And fortunately, you guys are very good at following a schedule, but the compliance, it's hard to do that for a lot of patients. But the Invega is an option. The other thing about, there are injectable forms of Abilify and Invega that, and actually I think there is for Risperdal now too, that they last longer in the system so they don't have to take them every day. But I know a lot of patients aren't very cracked about getting shots. The Rexulti, again, that's kind of one of the newer ones, but it's been very effective as an augmentation for depression, but also as a mood stabilizer. It helps on the depressed end. Vraylar doesn't have indication yet as an augmentation. It helps more on the high, but I've seen it help with the low moods as well. Latuda or lorazepam, it's been around for a long time. Actually, it's getting ready to go generic. And it's, again, there's some patients, they just do better on it, especially with the depression, but it can be very sedating at higher doses. Safras or acenapine, it's a dissolvable, and there's a wild cherry flavor, and it can be effective, but not many patients, if they have any sensory issues, they're not going to be able to tolerate, because they have to dissolve it under their tongue, and then it numbs their tongue for like the next 15 to 30 minutes, and they don't like that very much. But when they can tolerate it, it can work pretty good. Lybalvi, and that's a combination of it's olanzapine with samidorphan, and again, so it's like the Zyprexa Plus. It's newer. I've only had one patient who's tried it, and it made him too sedated. He was too sedated on it, so he didn't stick with it. Caplyta is also another newer medicine. It's indicated more for mania. And then Clozaril is an older antipsychotic, but you have to prescribe it, you have to go through a specific training and get checked off, and you have to get blood work like weekly. You have to get lab work before you prescribe it. Then you have to get it weekly, and they won't dispense it from a pharmacy, and there's only certain pharmacies that will dispense it until they get results of that lab work, because it can cause it can be pretty serious side effects. Lithium is the gold standard for bipolar disorder, and it alters sodium transport, which is and that has a calming effect on the brain. So again, sometimes we use it as an augmentation for an antidepressant, but it's one of the best that we use for mood stabilization. But people hear lithium and it scares them, and they're like, oh, I don't want to use lithium, that's too frightening. It is one we have to do blood levels. It can be thyrotoxic, so it can be hard on the thyroid, so we have to not only monitor levels of it, but we also look at thyroid levels routinely, and then kidney functions, because it's metabolized by the kidneys, so we have to make sure that those are fine. And I've had some patients I've had to wean off of it or come off of it because of the kidneys functions not being decreasing. The ones who do well on it and they have thyroid problems, we just put them on thyroid medicine, and it takes care of the problem. Because some patients, that's what we had to do, because that's the only thing that's really worked well to help control their mood. The other benefit is there have been multiple studies that have shown that lithium really has some suicide protection benefits. So if I have patients that are bipolar or have significant recurrent depressive episodes, I oftentimes will augment with just a little bit of lithium, like a 300 milligram dose at night, and just enough to kind of help. And it does help in that way in terms of the whole anti-suicide. Then we look at what happens like potential mood destabilizers. If you have a person and they have a mood regulation disorder, and whether it be, mood disorder, NOS, or they have bipolar 1 or bipolar 2, the SSRIs, especially fluoxetine, is very activating. So if we choose, like say we have a person and they're depressed, they're bipolar and they're in this depressed phase, I may use an SSRI. I don't leave them on it very long. You put them on it for a week or two until the depression starts to lift, and then you can take them off of it. You just want to get them out of the ditch, but not keep them on it so long that then it throws them into a mania. The SNRIs, too, sometimes increasing that norepinephrine can be too excitatory to brain chemicals. The stimulant medications used to treat ADD, especially, they're the methylphenidate amphetamine-based. Those can be, they get in, they work right away, and those can also trip people and really throw their mood into a mania. And again, that's when we call it activation, and that's where you stimulate emotional, behavioral, or cognitive processes. So they get racing thoughts, they become more oppositional, or just kind of sped up, and that's what can happen with some of these medications. The next condition that we oftentimes use, and I'm not sure what the comorbidity is with DCC, but I'm sure that it's seen some. But tics are involuntary movements or sounds. They're fairly common in children. Even like 15% of children will have a tic at some point. 50% go away by the age of 18. Motor tics are like twitches, and they can be pretty mild. Like they just eye blinking. It can be like just a shoulder shrug. Then there can be complex where they will do it all like they'll grimace or shoulder shrug. And again, it's interesting because I've been with patients in the office and I'm like, well, how long has he been doing that? And they're like, what? Because I think sometimes parents don't notice it because they can be pretty subtle. I just had a patient in this week, and that's actually for him it wasn't so much of a motor tic. I believe for him it was a dystonia, which can be a side effect of the atypicals. But he kept, like he was in his chair, and he kept readjusting his position, pushing himself up. It just didn't seem, just excess motor movement. And then their phonic or verbal tics is when they make noises. And it can be like just clearing their throat or humming, sniffing. If they have a combination of those, they're typically diagnosed with Tourette's syndrome. So again, a combination of motor and verbal tics. Males are 3 to 4 times more likely than females to develop Tourette's, and is very highly comorbid with ADHD, anxiety, and OCD. And I've seen, I have one patient in particular, he's a complex guy. He's got bipolar 1, autism, OCD, ADHD, and Tourette's. And he was kind of, really was tough to treat because some of the medicines, at first we thought some of his tics were side effects from the medicines, but they're not. And he's actually, now he's doing quite well as an adult, but we still have to make adjustments on his medicines to control his symptoms. We always say, too, like it's a rule when we treat, a third of the time, we use sometimes stimulants will increase tics, but like we say, a third of the time stimulants will make them worse, a third of the time they'll get better, and a third of the time there's no change with or without the stimulants. And again, there's been research that really shows there's a sizable number of kids who have severe tics or Tourette's who have a relative with OCD, which really suggests that there's a genetic condition, a connection between the two, and we certainly have seen that. And so again, some of the more common motor tics that we see in Tourette's include eye blinking. More complex is if they like touch or smell. So again, you just look at more complexes. There's increased motor movement involved versus simple. The shoulder shrugging or stepping in a certain pattern. Nose twitching. And again, think of it being bigger motor movements are the more complex. And then again, if you look at some of the more common verbal, the complex verbal tics are the coprolalia, where they say vulgar words, or they repeat others' words or phrases. I had a patient last year who had been, oh my gosh, he was ostracized and was like, he was in trouble all the time at school as a middle school age boy because he would say cuss words, and they just thought he was just all attention seeking. And he had Tourette's syndrome, and he had ADHD, and he had not been on the right medicines, and we got him on the right meds, and it's amazing. He's happy now. I mean, he came to me. He was overweight. He didn't smile. This is a little. I had known him through a friend before, and just his personality was gone from meds that he'd been on. And once we got the meds, he's back. He's in middle school. He's doing great. But again, getting the right diagnosis helped tremendously. Medications that we use to treat tics and Tourette's are like catapress and clonidine, which is clonidine and Capvey. They can be used in higher doses to treat high blood pressure. There's Tenex, Strattera. Strattera has shown some benefit with tics, although I will say I haven't used that a lot. The tricyclics can sometimes be effective if the clonidine or Capvey or Tenex aren't effective. Klonopin, sometimes the Ativan can be helpful, and then the high-potency antipsychotics. And sometimes people will use Risperdal first line to treat tics. As a rule, I tend to start with clonidine or Tenex. The next condition I'm going to run through, this is ADHD, and it's the most common psychiatric and inherited disorder in children, and the most inherited psychiatric disorders. And 70% of children with ADHD will continue to have symptoms into adolescence, and about half will continue to have them and have those symptoms into adulthood. We used to think kids outgrew ADHD once they hit adolescence. What oftentimes happens is the hyperactivity goes away, but the inattention doesn't. Girls, as a rule, tend to have more inattentive symptoms, but not the hyperactivity. So oftentimes females are they're missed. They're not picked up as having ADHD in school. When you look at what really ADHD is, it's executive function deficits. And there's an excellent article, I referenced it at the bottom, by Thomas Brown, called The Executive Functions Describing Six Aspects of a Complex Syndrome. But we look at activation, like getting started, organized, and initiating work. Focus, like staying focused, sustaining and shifting attention to the task at hand. Effort, regulating alertness, sustaining effort, and processing speed. There's an emotional executive function, which is managing frustration and modulating emotion, so not getting too upset about little things. Memory, using working memory to access recall, and then action or activity, so monitoring and self-regulating activity. When I always think of it as like when you have ADHD or executive function deficits, it's like the secretary in your brain takes off and you're on your own. So it's hard for people who have it to stay focused and to stay, and there are different measures, that sometimes computerized measures to assess that. We don't use those in our office currently, but I know what they are. They'll have to have patients, and they have to look at, every time they see an X, they'll see a whole succession of letters, and when they see an X, they're supposed to hit the space bar on the computer. But what happens is initially it's very regular, and then there's a long pause, and then the numbers or the letters start coming more quickly. And what you see is over time, because it's so repetitious, it's so boring, they don't stay focused, or they hit the space bar, and so it kind of looks at how much impulsivity there is, and how much ability they have to sustain focus when there's not interesting stimuli. I think that sometimes computer games right now increase the ADHD symptoms because the images flash and keep them. But then reading a book becomes like too boring. Yeah, this is the whole thing. If you're going bald, it's kind of some of the things kids say when they have ADHD. It's like, oh wow. I've had parents who and again, have sometimes thought they're just really being very difficult. But I'm like, no, they really doing the best that they can do, and they just can't stay focused and calm. The stimulant medications are the ones we typically use, and I always think, why would you stimulate the brain? But they stimulate dopamine and norepinephrine receptors. So different than the block, the SSRI, it's like how they block. These work by when they're in the bloodstream and they get into the brain, they cause those receptors to like pull norepinephrine or dopamine in, but then when they leave the system, they get out of the bloodstream, they quit working. So they're time limited, and they work typically pretty quick. There are lots of different, there are some that get in and work like within like 30 minutes to an hour, and they may wear off by 4 hours. So those are more the immediate release, but most of these are available in longer release formulations, and there are a lot of them. And I just have, like the methylphenidate-based, I've typed out here, there's Ritalin, Focalin. Focalin is like Ritalin, that they took the molecule and they split it in half and got rid of the most side effects, so it's dexmethylphenidate. Then there's Concerta, Metadate CD, Methylin, Jornay, Adhancia, Abtensia, Cotempla, Daytrana, Quilichu, and Quilivant. And there's newer ones coming on the market. It's pretty amazing how many medicines there are out there. And again, some act short acting, others act long. We prefer the longer acting because there's less abuse potential and fewer side effects as a rule. But the longer actings cost more, and oftentimes insurance doesn't want to pay for them. The methylphenidate-based stimulants tend to work more primarily on dopamine, and they work a little bit on norepinephrine, but they tend to work more on the dopamine receptors. The amphetamine-based stimulants work pretty equally on the norepinephrine as well as dopamine. So I always look at them as being a little broader acting in terms of their helping with ADD. And there's Adderall, Adzenys, there's Dynavel, Evykio, Mideas, Procentra, Vyvanse, and Zenzidi and again, the Vyvanse is a prodrug. It's interesting, it's like an Adderall, but they connected it to lysine, which is an amino acid. So it takes a little longer to work, but it lasts the longest. And we don't get the variability that we sometimes get with other stimulants. So as a rule, it tends to cause less irritability than some of the other stimulants. The downside is because it lasts long, it can sometimes make it hard for people to go to sleep at night. So we've had to kind of switch meds because of that. Jornay, which is it's a methylphenidate. It's one you take at night, and they take it at night, and then it has to go through the GI tract, and when it gets into the lower GI tract is when it's got the right pH, and that's when it gets released. So it's on board in the morning when they wake up. Non-stimulants to treat ADD include Strattera, Wellbutrin, the clonidine, and 10X, which those help more with the hyperactivity part and if they have comorbid tics. And then Provigil or Nuvigil, we'll use those off-label because they increase wakefulness. I can't say they're particularly great at treating ADD, only if the primary symptom is fatigue. Conduct disorders are behaviors that violate the rights of others or disregard societal norms. Oppositional defiant disorder is behaviors that they resist or disobey authority figures. There's no specific regions of the brain that are involved, so you have to, as a rule, you have to treat what the underlying condition is. So it may be that there's anxiety. It may be that there's former trauma. It may be that, there could have been bullying. There's different things that can underlie what causes those. So the biggest thing is that we have to look at what's underneath, and oftentimes start with therapy, and then decide if we want to go with using meds. Autism spectrum disorders are developmental disabilities that cause significant social, communication, behavioral difficulties. And again, there's a spectrum from severe autism with marked cognitive impairment to more mildly atypical behaviors. What's interesting, and I love this quote by this John Ortiz. I heard him speak once, and I'm not exactly sure what, I know he is no longer alive, but he was wonderful. He had a lot of experience in people with autism and Asperger's. I always love what he said is people with autism live in their own world. People with Asperger's live in our world, but on their own terms. And I really think that's kind of a good way to describe it. And I know autism spectrum disorder, or PDD-NOS, actually now under the DSM-5, it's all under autism spectrum disorder, is highly comorbid, that we oftentimes see that in individuals who have DCC and can have a lot of rigidity. This goes through, again, some of the different it kind of separates out the different, like the PDD-NOS versus autism versus Rett's versus Asperger's. But again, now in the DSM, they kind of put it all under one umbrella, one thing. In terms of treatment for autism spectrum disorder, certainly behavioral treatment's the most effective, ABA therapy and social skills training. There's no specific medication for the core disorder. but we will oftentimes treat like the repetitive behaviors. For a long time, where I used to work, we referred to Risperdal as vitamin R, because I saw some pretty miraculous changes in patients who were on the autism spectrum when we used atypical. They start relating better, and I've even had one girl in particular who didn't have much language, and once we treated her with an atypical, we got language. Now, there was echolalia, but I mean, she still had much more language, and her mood and all that improved. So again, typically you aim for what are the target behaviors that are causing difficulties for the person who has an autism spectrum disorder. So the SSRIs or anafranil can help. The atypicals, especially Risperdal, Invega, and Abilify, Zyprexa, and Geodon. For severe irritability, the atypicals work. And then for treatment, if there's aggression and self-abuse, the beta blockers, which again are used at higher doses for blood pressure, like propranolol, clonidine, 10x, the benzodiazepines, and lithium or an anticonvulsant. And I put naltrexone, and I highlighted that because that's a newer, it's one that's used for people who have opiate addictions, but it can be very effective for aggression and self-abusive behavior. And actually, I have one patient who has true kleptomania. He sees something, he can't stop, he cannot stop himself from taking it, and then naltrexone has really helped decrease some of that. So it's kind of one that we use a little bit newer. I'm going to look at my time. I don't want to run out. I don't know if you guys have any questions. Yeah, any questions? These are in the slides if you want to look at them. But again, the psychotic disorders are more like thought disorders, hallucinations, or paranoia. And so again, typically what we use on those are schizophrenia, schizoaffective, or they can have a brief psychotic, or that's usually in response to a stressful event. It can also, there's some people who have it related to women that have it related to hormones. But again, what we do is we use the atypical antipsychotics, and they work by blocking or partial agonizing the dopamine receptors. And there's a list of all the, and again, there's generics. I put on there which ones are available in generics, and there's a whole list. There are a lot of them. It's amazing how many have come about since I started working in psychiatry. The important thing to remember, antipsychotic side effects is we always look for tardive dyskinesia or any extrapyramidal symptoms like abnormal lip smacking movement, shrugging, any of that. And if we see that, we usually back off on the dose, or sometimes we have to use like a Benadryl to offset that. Neuroleptic malignant syndrome is not, it's a life-threatening, knock on wood, I've never seen it. It's very rare that you see that. I think it's with more of the older psychotics. Weight gain's fairly common with most of them. Elevated for some, and again, if we know that, we just monitor that. They can have like increased lipids. Some can cause a little bit of low blood pressure. And then there are some that are known to cause prolonged QT syndrome. So if we know that, we just get baseline EKG and follow that. Let me see if that's, and this is, again, it kind of goes through. This is, I just mentioned earlier, like when we do, this is an example of that genetic testing that we do to look at meds. Like on this patient, it showed that for like these antidepressants in the green are ones we should use, he should be able to respond to and not have adverse effects. But in the yellow are ones, and at the bottom it says like one, well, I guess that got cut off. Like the serum level may be too high. And then the ones in the red column, it's like he's got much more risk of having side effects and a poor response. The other potential risk of all meds is a paradoxical, where you get the opposite effect, an allergic reaction, an ineffective response, drug interactions with other meds, and then liver, kidney, or endocrine stress. So we, as a rule, if you have patients on meds, we will monitor labs, and I always look at interactions of meds to make sure that they're not that they're not at risk. The other thing, too, I want to mention is when you have a person who's got, especially depression, chronic depression, or brain stress, is the brain quits producing a chemical called BDNF. Think of it as like brain fertilizer. And they've really shown like brain cell shrinks, like this, the cells aren't healthy. So you really want to treat it as soon as you can, and so it becomes chronic, and that you end up with a, because the longer it goes on without treatment, the harder it is to treat as well. Let me see. That I went through, and again, I look at just restoring brain balance. It's medications, and calm environment, sleep, improve, nutrition, being in good physical health, a predictable schedule, and exercise. All those things are going to optimize your child's or functioning and people's functioning, probably functioning for all of us. So with that, I'm going to kind of jump and see if you guys have any questions. Yeah. Mm-hmm. Uh-huh. Mm-hmm. Yes, it is can be given PRN. I do have patients that have that, and there's like a 0.5 milligram dose, and they'll either give a half to a full one of those as a rule, and it just kind of helps. It gets in and starts working in about 30 minutes, and they just use it kind of as needed for agitation or, yeah. I have a couple patients, several patients actually, that's kind of their rescue. There's some patients who have worse, they have a harder time during the full moon, and I have some patients that they don't sleep, so they'll use that medicine during that week, and then they kind of go back to not using it. But yeah. Yeah. Mm-hmm. That certainly is that is a possibility. The other is, I will tell you, I've done that gene site testing on patients, and there's not a genetic marker for the amphetamine-based meds, but there are. Oh, I had one patient, and all of the ADD meds were in the red column, and it said that at risk for adverse side effects or not a non-responder. Yeah. Uh-huh. What's that? You know what? Again, on that one, I've seen patients who have benefited from it, but I'm not in that field. I have not, but I know that some patients use it and they feel like it's helped a lot with anxiety in particular. But our state, we have medical, we don't have medical marijuana. We don't have medical marijuana in Indiana, not yet, no. But they use the gummies, but it's not medical marijuana. Not, right, the CBD. Mm-hmm. Have they ever back? Because sometimes I'll do that. It's like, you know what, we're adding, let's back off and let's see what's helping. And sometimes we go back to square one. Right. Right. Say that again. He's underage. Right. Mm-hmm. I think that's at least what I've read. Is it seems like that where it's helped the most is with seizures and with pain. But again, I have some patients who it's helped some with, they use it for anxiety. Right, right. Mm-hmm. Right. Mm-hmm. Uh-huh. We do that sometimes because, if we want a stimulant, because, they're more robust in helping with ADD, but then Strattera or Wellbutrin, which are non-stimulants, because they maybe don't tolerate a higher dose or a higher dose doesn't work, we use something in combination. Yeah, which is, again, that's not unusual. It's not unusual at all to use, for patients to use, especially a stimulant with a clonidine or a 10X, something that kind of helps with the hyperactivity part, but I don't think it helps as much with the attention part. Yeah. Mm-hmm. Yeah. Right. Right. But I will say, go ahead. Yeah.
Does a behavioral pediatrician, I'm in the process of moving forward, getting an opinion from a behavioral pediatrician. Are they more helpful or more knowledgeable when it comes to meds?
You know, it depends probably on the behavioral pediatrician because I used to work with a guy who was wonderful. He was much more conservative though in his meds. So to me, it's helpful if you have like a behavioral pediatrician who consults with a psychiatrist, who has, and that's what we ended up doing in our office, and that kind of helped. Yeah. To have what done? The genetic testing, you know, it's really pretty easy. You can have any, you know, I think my email might be on there. Right. Yeah, that, or if you don't, send me an email, let me know. I mean, there should be someone, because it's pretty, because I can even, because I've had patients before that, there's siblings of my patients that I'll send, I can have the kit shipped to your house. Yeah, you just swab inside. You use the thing. Oh, it is very user friendly, I think. Right. You know, the other thing I didn't mention is vitamin D. I have everyone on vitamin D because they don't get enough vitamin D, and low vitamin D levels will get headaches and fatigue and depression. So, what's that? B6. We use that sometimes to off. I mean, sometimes I use it, but really, if they're on Keppra, they're on vitamin B6 to offset the irritability. It could. It can. Right. It's probably worth. I think if you can use like vitamins, it's worth trying. Yeah. I think as a rule that helps decrease irritability and yeah. Okay. Yeah. Get a prior authorization. It's knock on wood. That's great. Uh-huh. Well, so you may need to stay on a dose of it. stress, yeah. Right. Wow, that is great. Sometimes too, just a lower dose of the Topamax. I mean, typically you need higher doses of Topamax for seizures, but lower for the. Okay. Wow. How old? Okay. Yeah. It does. There's a really good book. It's called Yes, Your Teen is Crazy. And I love it because it's got a really good chapter in it on like the changes that go on in the brain starting about age 9, 10 up to early 20s, which is why they're higher risk for depression, why they're higher risk for